okay? So it's for completeness for you to know, like, oh, this makes sense, this is gonna make the skin softer, so therefore I'm helping with wax because that's how that kind of looks, but I'm not gonna have you diagnose anything. Okay, so your isotretinoin, seriatine, another oral medication that we have. This one is a retinoid, so still in that class because that's what we were talking about yesterday. Same kind of mechanism, decreasing some of that inflammation that the patient is going to have. And then looking at your clinical use, you can use this with or without that UVB. Remember, the UVB was going to help decrease how much, or help with that cell proliferation, right? And try to break up some of those plaques that these patients may be experiencing. So you can use it with the UVB, some of your biologics. Again, the more meds that you add on, the more difficult it becomes for your patient for compliance. But we do want to start with the least toxic or the least irritating thing that we can. One of those exceptions would be your benzoyl peroxide, because for some patients it is irritating, but that's like the best first line thing. Y'all eating cookies. You gave everybody a cookie except for me for breakfast. I'm just kidding. So make sure you're paying attention to when you can, when I'm asking you questions for the exam, I'm not going to expect for you to like stack stuff. If I am, I will say, oh, they tried this and this didn't work. Or they have this, what else can you add on to it, okay? So don't like create or assume anything when you're looking at these scenarios, okay? Because in real life, you can mix and match everything. Just make sure if it's on the slide as far as, yes, I can add these things together, they're not contraindicated for me to use them together. I won't make up drugs, never try to make up drugs. Same thing, follow the pattern, okay? When you're looking at this med, it is better in the fact that you have less organ toxicity when you're comparing it to your methotrexate and your cyclosporin, but it does have a REMS program, its own program, I shouldn't say a REMS program, the Do Your Part program, so make sure that you're writing PART, and what that is it's called the Pregnancy Prevention Actively Required During and After Treatment Program. That's what the Do Your Part stands for. So again, just like we talked about with our isotretinoin, how they can't get pregnant, this is the same thing. Again, we're just trying to make sure that they don't get pregnant. You see that this can last for up to 3 years after they have taken their last dose. So if you have a patient who is planning on becoming pregnant, you need to make sure that is not in their plan for the next 3 years, right? So if I told you I was complaining of any type of issue or I had any type of derm issue, and I'm telling you I want to become pregnant in the next year, this is not a great option for you, right? Because this med is going to be in my system for up to 3 years after I stopped it, okay? So they're still going to be trying to make sure that they don't become pregnant during that time. Contraceptives, birth control, condoms, all of the things, they will be trying to use those. Other things that you see, again, dryness. So this kind of looks exactly like we saw with our Accutane, very similar adverse effects, okay? The program is different. Your isotretinoin, we had iPledge, and on this one, we have the PART program, P-A-R-T program. Okay, our TIMs, these are the same things that we had already saw, okay? They're coming back up again. You already saw your mechanism of action, same exact drugs that we've already talked about when we were looking at our eczema. So again, mild plaque psoriasis is kind of where you're seeing it here. This was the one that we said was our steroid sparing. So if I had a patient that was on steroids for a long period of time, or their disease was flaring, right, for a longer period of time, I can then put them on this to say, okay, when I have you off of the steroid, now I can put you on a TIM. Once I take you off of the TIM, I can put you back on the steroid, because sometimes a flare may not respond to just that steroid how we would typically hope that it would, okay? So same exact things that you've already seen here, adverse effects, black box warning, all this stuff is the same. Your cyclosporin. So most of the time when I talk to you about a generic that has several brand names, it's like, oh, it's the same exact generic, like the same compound, right, the cyclosporin. This is different because these brand names are not bioequivalent. What that means is if I were taking Sandamune and the pharmacy did not have Sandamune, or if we took Sandamune off of our formulary, you can't just say, oh, it's fine, get NeoReal. They are not equivalent to each other. So the patient may not be treated properly if I switch those brand names. So the brand names matter when you're looking at cyclosporin as far as, so if I told you, oh, a patient had Sandamune and the pharmacy didn't have Sandamune, now your job would be to find somewhere for them or tell the patient you need to find somewhere that does have that brand if they were put on the brand, and vice versa. Okay, so bioequivalence means they don't go into the body and do the same exact thing anymore based off of the composition and the brand names. Okay, so there is a difference. Your Sandamune, you see that you have the IR capsule that's made, and then when you look at your NeoReal, this one is formulated differently, and that's why we see the difference in the bioequivalent. That absorption can sometimes vary depending on the lot, which is like the you know what a lot is, the lot of that drug. Okay, so drugs have different lots, so that's where it's saying absorption variability, and so that's why we don't just say, oh, I'm going to switch one for the other. The way that one patient responds also may not be the same way that the patient next to them responds, right? Because we all are different. Our body is going to respond to our drugs differently. Looking at your clinical use, this is like a last line thing. This is for something that is going to be, or if I tell you that like your patient is very, very severe, you can see this used. Or if I've tried my other treatments, so everything that we talked about before, I've tried everything else and nothing is working, now I would hit me using one of my cyclosporins. Sorry. So looking at where you can use it. Remember we talked about the palms, our feet, right? Our soles of our feet, palms of our hand, thicker. What vehicle would I like to use in those areas? Cream, ointment, gel, in thick areas. I can use creams. What's good? What else is good and it's occlusive? And ointment is also a thing, right? And if something is wet, what do I need to do? What's a good vehicle that I can use to like dry things out? Okay, so don't forget that very first part of the slide deck, all right? Because it's going to come up. Y'all are going to see them again, okay? Okay, so looking at this, just understanding again, if you have your biologics, our biologics increase our risk of infection, right? We know that, and those are all the things that end in NAV. When you see that, you want to stay away from them if you can. Sometimes we cannot. So you see that this is an alternative to those biologics. They are not as patient-friendly as far as like the side effect goes, but the cost is better for them. So again, when insurance comes into play for some of our patients, and this isn't something that any of us worry about, but if you have a patient who can't afford things, your cyclosporin is going to be a lot cheaper than them getting one of those monoclonal antibodies, okay? And then look at the use being limited due to the adverse effects. So like I said, it's good for the pocket because cyclosporin is cheaper, but when you look at the adverse effects, it's like a tornado, okay? Nephrotoxicity, potentially cancer, hypertension, triglycerides. So all of this means monitoring. That's what you should be hearing as a PA, right? Several interactions. This drug also has several drug-to-drug interactions with other things. Renal function, okay? You got to make sure that you're monitoring that. And then this is also a category X. They should not be using this while they're pregnant. Sorry, category C, but don't use it while they're pregnant. So cyclosporin C, cyclosporin not bioequivalent. Know the difference between your Sandamune and your NeoReal. So with the Sandamune, it has an I in it, so you can remember that this is like your immediate release. And then your NeoReal, just understand that it has emulsion, microemulsion with your Neo. Like it's newer. So this is like a newer way that we make meds. Okay. What else was I going to say about this side? That's it. Okay, apremilast or Otezla. Probably see a lot of commercials now with Otezla. And you see that it is a PDE4 inhibitor, good medication. it is going to require a little bit more work from you because it does require a prior authorization. Again, that can always come and go, so make sure that you're looking it up when you're doing the TRICARE formulary lookup tool to see if you require that prior authorization at the time. So decreasing, again, those inflammatory mediators, so that way we are an anti-inflammatory. And then looking at, if you remember that in bold, that's enough. I don't need you to remember all of the different mediators that are coming into play. And then moderate to severe for your patients as far as who you're going to be treating. And then looking at this, your phototherapy or your systemic therapy, that already tells you that your patient is likely severe, okay? So this is saying like, hey, if they're already to that stage and that's still not working, I could potentially give them the Otezla. Not as good as my cyclosporin, right? Not as cheap as my cyclosporin, but I don't have those same side effects, and it's less work for you to monitor so many things in your patients. You see that you have some GI issues, which ultimately could potentially lead to weight loss because they could have the diarrhea, nausea, vomiting. Depression and suicidal ideation. So of course, if somebody is already in that mental state, then you need to be monitoring that closely. But other than that, these are very straightforward things, bigger thing, contraindicated in pregnancy. Interactions, watch out for our inducers. Methotrexate. This is an old drug. You will see it used in cancer patients in different conditions. We can potentially also use it in our derm setting as well. So you have your folic acid antagonist. Remember this because we're going to talk about the supplementation that is required when they're taking methotrexate. And then with that, what it's doing is it's inhibiting your purine synthesis. When we think about purines, that's part of our, when we're talking about making RNA, DNA, it's disrupting that whole chain for your patients. So keeping your mechanism in mind is also why I'll say, I think it's probably on the next slide, but it is a category X because of that disruption that it has with the purines. So if I'm making a baby and then I have a drug that can interfere with my genes replicating, I'm not going to use it. So that's why when we get to the next slide, you'll see that it's category X, and remember the X because it has it there in the name. Immunosuppressive, anti-inflammatory, severe, refractory, like last line kind of thing, unless I immediately just say, hey, your patient is super severe. Okay. Adverse effects, lots of different things that can happen when patients are on it. When you look at your stomatitis, this is essentially saying that they can get these ulcers, and the way that we try to prevent that is they will take folic acid supplementation every day except for the day that they take their methotrexate. So when you prescribe methotrexate, this is a drug that causes a lot of errors because some patients will take it every day, and most of the time they're not going to be taking this every single day. You usually give it, and it might be, it's very unique dosing depending on the patient, individualized to the patient. But make sure that when they're doing the folic acid, you understand that that's trying to decrease the stomatitis, and you're doing it on the days that they are not taking their methotrexate, okay? If they're taking their methotrexate that day, they should not be taking their folic acid that day. Myelosuppression, pulmonary toxicity, hepatotoxicity, monitoring, right? So just make sure you're aware of all of these different side effects, and then the fact that you're using your folic acid to decrease your stomatitis. Category X, we talked about this, so making sure that you notice that in this one, it's for men and women that have to be careful when they're taking this. So while they're on the medication, understand if they need to be practicing either abstinence or using protection so that they don't cause their partner to become pregnant or so that they don't get pregnant. With this, again, it's not enrolled in like the REMS programs like we talked about with our other two meds. This one is just saying, hey, be cautious and make sure that men wait 3 months after they've stopped it, so after their last dose, and women have to wait 1 menstrual cycle. Okay? Remember the 3 months is because it takes that long for the sperm to turn over all the way, and so that's why they're having to wait the 3 months in the males versus the 1 cycle for the women. If you have any overdose that occurs, we have leucovorin that is available. And so what you do is you're essentially trying to give that cofactor back that will be depleted if they had too much methotrexate. Okay, so there is a rescue for it that we can be using. The sooner you use it, of course, the better, because we want to try to make sure that we don't wait too long, because then it's a lot of recovery, more leucovorin that we would have to be using to supplement. Okay, so it can be used 24 hours after methotrexate. We don't prophylactically give this. If something happens, patient presents like they're having that toxicity, then that's whenever we'll do it. Okay, so just know how it works, know what the rescue is. Okay, so this has an antidote to reverse it if I gave too much. Okay, and this is not something that's taken every single day. Our biologics, same things that we've kind of hit on before, different mechanism that you have is your pro-inflammatory cytokines. You're trying to block them. So again, I want to decrease inflammation, which is my ultimate end goal. My alidubumab, infliximab, etanercept, ustekinumab are all different types of monoclonal antibodies, or our biologics. When you look at them, moderate to severe, these do cost a lot more money for your patient. So those other options that we talked about are a little bit cheaper. This is the ones that cost more money for them. When you look at this, you see, I want you to pay attention to your infliximab. You see that this one is the most effective option that we have available. And this is an IV medication, so they would come into clinic to get these infusions on their, whatever their schedule is that you would create for that patient. A lot of times they would end up out of your area and somebody else would be handling this for you. But remember, most effective IV route. I don't need you to remember all of the other options. Just know that the drugs are biologics and how they work. Looking at this, also your clinical use application-wise, moderate to severe. And then looking at this, I can add methotrexate or my acitretin with my biologic. Now, this is something that depends on how the provider wants to treat. Do they want to start with the methotrexate or the acitretin before they added the biologic, or they can add both of these things at the same time, depending on how severe their patient is? Okay, so that would be on when you're doing the combo, it's more on the severe end, not if that person was moderate. Infections, because we said that it's a biologic, okay, so making sure that you're testing for TB prior to, because you can have reactivation. I think we talked about this when we looked at, was it arthritis? Did we see this, or gout? I think y'all saw some of these maps. We used some of these. Less toxic, when we're comparing it to our previous meds, our methotrexate, cyclosporin. So I'm not having to worry so much about the toxicities and the monitoring. So it's cleaner, but you're paying for it, okay? And then when we talk about pregnancy, it's unclear on if these are safe during pregnancy, because we don't have enough studies to tell us. So when I don't have that, I just tell y'all don't do it. All right, warts. Several different types of warts. We have warts that can be on the outside of our skin. You have genital warts. They still happen. Caused by HPV doesn't necessarily mean that they always are going to be genital. Okay, so when you see warts, I will tell you again that they are warts. You just need to know what options we have. So when I talk about prophylactically trying to prevent someone from having an HPV infection, I have two vaccines. I have Ceravax and I have Gardasil. A lot of our commercials are targeted at the Gardasil that you can see, and they have those really young kids, and I'm looking like, dang, we already have to do vaccinations in these 7-year-olds that they're showing on the commercials. So again, what we're trying to do is prevent those genital warts that could potentially happen in these patients, which then could potentially lead to cervical cancer. So that's why we're trying to vaccinate now, and we came out with these vaccinations. Looking at the, this is treatment, this is prevention, okay? So your vaccine is trying to do it before, and then your physical destruction is like after. So they already have a wart, and now I'm trying to treat it, okay? So looking at this, your keratolytic agents, these are the ones that we typically use, and then you have cryotherapy, laser removal. You could potentially also do surgery. So we're gonna go through our keratolytic agents. These are things that you will likely be prescribing. So salicylic acid, pedalophylox, podophyllum, and micromode, and cyanocatechins. Okay, so different options that we have. And then when you're looking at these, this is the most common one that we typically use. And probably our pedalophylox would be the next one. So this is kind of in order of how you'll see them. Some of these also with your salicylic acid are over the counter, right? So you see how this compound W, they can go into the pharmacy and just buy this themselves. They don't need you to prescribe it to them, but we do have it available if you would like to order it prescription-wise as well. 1 to 2 weeks is where they should start seeing an improvement in the wart, so the size should decrease, but it doesn't necessarily mean that it will be completely gone until sometimes a month or two by the time it completely resolves and it's destroyed. All right, your imiquimod. When you're looking at this, this is a topical immunomodulator. And what this is doing is trying to induce an immune response, and it has some antiviral properties to it. Looking at it, I can use it for my topical skin lesions. I can use it for genital and perianal warts that some patients may get. But this is only supposed to be for external. You have some times where people can have warts cervical. They can have it in the anus, and this is not a cream that they're taking and putting internally, okay? So make sure that people know that this is just for external use only. You can see that I can add it with the salicylic acid, which is also going to destroy it, make it a little bit better because I'm combining this and I'm tackling it in 2 different ways. And then you see that you also have where you're saying I can, when I'm doing this, my plantar warts versus me having that cryotherapy. Cryotherapy depends on what clinic you're in. You may be able to do that also in your clinics. I know that sometimes some of the PCMs can do that without sending you the derm. And then these are just other indications where you can see it. Most of the time you're going to be using it for the warts. Avoiding pregnancy, and then our adverse effects, just making sure that you understand it's very superficial, very well tolerated for the most part. People don't have a lot of things going on. So just local response on where they're putting it. And make sure that they wash their hands after, so before and after washing hands with any of these topicals that we're talking about. Pedalophylox and your pedalophyllum resin. So your pedalophylox, good medication. You will be easily able to prescribe this. Patient goes home, they use it. What it's trying to do is it is trying to kill essentially those cells that are proliferating and causing that wart that you see. Only, again, external, so same thing as our previous slide. I don't need you to remember the dose, so that's just there for your awareness. And then looking at your adverse effects is the biggest thing with this drug. It's a very effective medication. So when you're applying this, it needs to only be to the wart. If you apply it to the skin, it will kill the good skin too. So anything that it comes into contact with, it's going to destroy it. All right? So that's why it's saying causes necrosis of your healthy skin. So if you are accidentally, like they accidentally drop it somewhere else, they need to make sure that they wash it off immediately so that it doesn't cause necrosis there. Some people, they will put Vaseline around whatever that wart is, like the healthy skin, to protect it, and then put on the drop. Okay? So make sure that you understand healthy skin could be a problem. And then not using it in our pregnant patients. And now, looking at our cyanocatechins. This is an expensive ointment that we have. When you're looking at this, understand that it's just trying to say if I increase apoptosis, then I'm going to decrease those cells. They're not going to live, right? So I'm trying to upregulate my apoptosis and modulate or downgrade the genes that are causing that inflammatory response. So therefore, then I can get rid of my wart. You see that this is a long time that they're going to have to use this. So every single day, they're using this for 16 weeks. So the adherence to this is kind of difficult, but any wart, like it's not gonna be an immediate response unless you do the laser or the cryotherapy and like try to freeze it off. Avoid it during pregnancy, and then like I just told you, the cost is very expensive. We don't use this as much because you see how they compare what the clearance rate of that genital or the perianal wart with placebo, like it was almost the same. So for the amount of money that you're spending for a small 30-gram tube, it's not worth it because of this effect. So it's not our most effective option that we have, but if somebody wants to try it, you can order it. Your memory jog, see this listed here. Make sure that y'all look at these because we do go through them and try to make sure that they're helpful for you and a good review for the exam. Okay. Let's look at steroids. I'm sorry, I'm coughing, y'all. I look at people how y'all are looking at me right now and they cough too. Okay, so steroids. We've been talking about steroids a lot in several lectures. Now this just focuses specifically on them. And we touched on them now, I think, for almost every single lecture that we talked about before, okay? So ELOs, same thing. Make sure you're focusing on the mechanism of action. Adverse effects are big with our steroids, and also understanding which potency your steroid falls into, okay? So that you can know, oh, I'm picking a high potency, which one is high potency? Oh, I'm picking low potency, which one is low potency? I would tell you where your test material starts. This is just background. So when you're looking at this, understand that we have corticosteroid and we have adrenocorticosteroid. Not exactly the same thing. One is coming from, where's my pointer? You'll hear us just always say steroids. That is how you will commonly hear people refer to it in medical practice. But we have glucocorticoids, and we have mineralocorticoids. Your glucocorticoid is where you have your cortisol. Your mineralocorticoid is where you have your aldosterone being your main thing. So that's why you see the CO underlined here, so that you remember that your glucocorticoid is going to have your main glucocorticoid is your cortisol, and then your main mineralocorticoid is your aldosterone, which is down here. Okay. So we talked about aldosterone already. We talked about how that deals with our water retention or reabsorption. And then when you look at your glucocorticoids, this is going to deal with our metabolism and our immune response. So when we talk about these, this is why you'll see some of those side effects that we will see from our drugs occurring, just by way of the glucocorticoid versus the mineralocorticoid. This is just telling you, like, hey, we need cholesterol in our body. Okay, it's a building block for our corticosteroid. We have to have cholesterol. So you're going to see. I'm not asking you this on the exam, but we need cholesterol, just a healthy amount of cholesterol. FYI, this slide, again, same thing, just breaking down your adrenal cortex, understanding that you have your ACTH, all the things that we've already talked about when we were looking at this HPA axis. So when we talk about steroids and how we have continuously told you already, if I'm giving that glucocorticoid, I'm supplying the cortisol, and so my body says, cool, you don't need me to do this anymore. I don't have to produce this. I don't have to worry about this entire axis. So the higher the dose of a steroid that I give, the longer that I give that dose of steroid, I then shut off this negative feedback system. I shut off this entire axis. Once I remove that steroid, it depends on the patient, but it can take up to a year for the body to start doing this again on its own. Okay? So just understand that this is why we worry about steroids. This is why we don't leave them on for a long period of time. This is why we try to spare the dose that we pick, the potency that we pick. So, looking at our glucocorticoids, again, you have your ACTH, and then you have your cortisol-binding globulin that is around. When you look at your ACTH, we already taught you that it's going to peak in the morning time, and so if you're having a patient who's in the hospital or for whatever reason you're trying to monitor or observe their cortisol levels, it's best for you to get that measurement, that lab in the morning. After meals, we may also see that this kind of peaks. So this is again why we try to give it in the morning to mimic that natural cycle that our body is going to have. When you're looking at your CBG, this is going to be increased by potentially if someone is pregnant, if they have a lot of estrogen, you can see where this can alter or increase your CBG. If I have a thyroid issue, specifically not enough thyroid hormone, so hypothyroidism, then that's where you can see a decrease in the CBG. And so just understanding that these things are all working together, and when we give a drug, it's not just a topical thing, right? It's not just the oral steroid. The longer we give it, the higher the dose, which is what you're picking. All of this system it has a cascade effect on several things being affected. All right, so this is where we'll start with your material that can be on the exam. So, mechanism of action. Remember that we said that our glucocorticoids dealt with metabolism, it dealt with your immunity. So the glucocorticoid is going to bind to the receptor to get those effects, to get some effects on immunity, to get some effects that will alter the metabolism. So when you look at your metabolic effects, increasing lipolysis is going to be happening. You see that I'm going to also stimulate that protein breakdown and things being, so like a lot of different things are going to happen the longer that I have my patient on these medications. My hematopoietic effect, again, just several different hemoglobin, several different things coming into play that are going to be increased. So if you're doing labs and somebody is on the steroid for a very long period of time, you may see falsely elevated levels of all of these cell lines. Your anti-inflammatory effect is the biggest thing that you see us using it for most of the time. So when we talked about all of our other disease states, we were saying this is going to decrease the inflammation that my patient is having. So again, this is that cascade that you saw as to where our corticosteroids are working. So higher upstream to prevent the inflammation. That's why we were using it in asthma. We use it in several different pain types of conditions where somebody hurts themselves and they have swelling. That's what our steroids are used for. So inhibiting that phospholipase to produce or to prevent that inflammation. So clinical uses are kind of tied back to that mechanism of action and all the things that it was hitting. So your inflammation, allergy, autoimmune disorders that the patient may have. So all of these are listed. If you just know the underlying, that is good enough, unless we specifically talked about a disease state previously. So like we talked about asthma and COPD, of course you should know that it's used there. But all of these other things, lupus, all of this, we didn't talk about that. So as long as you know the underlying clinical use, that is good enough. Our derm conditions, again, unless we have it in that derm lecture, I'm not going to throw a random disease state at you. So our derm conditions, cancer, you can see it used, adrenal insufficiency, we can see us trying to use that, and then these other things, don't worry about that, that's way far down and not in your wheelhouse, but also have to know that, okay? So remember the underlying things, only specifically if we had a lecture that talked about using a corticosteroid, are you required for the things underneath, okay? All right. This is just a summary chart saying, hey, here are the indications which we just talked about. Most of these are the ones that we have seen. We saw this in our allergy lecture, our asthma and COPD lecture, the Pharm lecture, where we said, hey, if I was going to prematurely go into labor, I could potentially give a steroid to kind of help that child, the baby's lungs develop. You'll also see this happen in some of our premature babies where they will give them a steroid to kind of help them get ready for the real world. So this is, again, just a summary slide to say, hey, here are these indications that we're going to go through in this lecture. Here are the preferred steroids that you can use. Note that some of these have the route. I will go over it later if it is something that you're going to specifically need to know. But don't try to remember all the routes because you have a big job when you're remembering what potency the ointments and creams are. Inhaled, systemic, and topical steroids. This is very similar to what you saw in that Pharm lecture. Okay, so just understand that your inhaled, this is for us to use in our pulmonary condition so that it's going to the site of action that I need it to go to. and not use for our exacerbations. What do I use for my exacerbation more? My SABAs. And then I can, if somebody is having a very severe exacerbation, and let's say they didn't respond to their treatment, their inhaled treatment before, I can give them that systemic option. Remember with my prednisone, that's my oral option, and then I had my methylprednisolone IV. This is for me to get a quick response for that patient who wasn't responding to anything prior, and I had to hospitalize them to get them under control again. Okay, so that's where you're seeing your PO and your IV options in regards to that. And then looking at your topical, again, these are going to be for anything that has any inflammation on the skin, bite, what have you, any disease state or derm issue that causes inflammation. These are where you're going to be using those medications. Okay, so topical steroids, that's what we're using them for, what we spoke about in our previous lecture. Make sure that you understand that these things right here, especially acne is the biggest thing. Your acne and your fungal infections are things that can get worse on steroids. So the longer and the higher dose, you're more likely to see those adverse effects increase. Okay? So that's that bottom bullet. My inhaled adverse effects, same things that you saw before, right? So the higher the dose, the more likely I'm worried about that growth suppression in my kids. And then I can have my fungal infection, so that's why I'm supposed to rinse out my mouthpiece, my spacer, rinse out my mouth after I have my inhalation. And then the larger the dose, the more likely I am to have those systemic effects. Chart, we saw this already, right? Short term versus our long term. So you remember it one place, it's going to be the same, right? And then this is going more so into telling you kind of what those atopic changes look like. So we said if I was applying this topically that I could see some changes in the way that my skin appears. I could see that my skin is starting to thin. And so that's why in certain areas I try to make sure that I'm picking a low potency versus a high potency. So again, just make sure you're aware of the atrophic changes that can happen. If somebody is telling you that they're having a lot more bruising, or they're like seeing their veins now through their skin, so that it's a hint that like their skin is getting a little bit thinner, you need to reevaluate and check on your dose. These striae that happen, this does not go away, okay? So once their skin is like this, it's like this, all right? And there are some disease states where we have to leave them on the steroid for a long time. So their appearance may alter, but that's the only drug that we have to treat whatever their condition is. Their diabetes may get worse because this is or you might cause them to have diabetes, but this is the only thing that we have to treat them at that time, right? Looking at your cutaneous and local effects, again, just understand that you can have hypopigmentation, and some people you can have hyperpigmentation, so we are very cautious, and if you ever go to the dermatologist, they are very cautious with giving a steroid, especially if it's a medium or a high dose steroid because of these issues. And then your ocular effects, it can worsen vision. So you see the cataracts, glaucoma, different things like that happening in your patients. Just make sure that you understand that we are trying to help them. We need to make sure that we aren't afraid to use a steroid, but just don't leave it on for a long period of time and forget that it's there. Make sure that you're clear and communicating with the patient so that they don't save it and continue to use it all the time or use it on a larger area than what they're supposed to. This is where you can see that you had an excess or that cushingoid experience and this cushingoid side effect. So that's what this is pointing out right here, right? So it's telling us all the same things that we saw on those previous slides, but it's just an acronym that's made up for that, okay? So the cataracts, ulcers, their skin, hypertension, infections can happen, the necrosis can happen, all of these different things that you're seeing here. So your cushingoid is your acronym for the previous things that we saw with our adverse effects. Also, I wanted to make sure that you understand too, this can happen if the body is also producing too much of the glucocorticoid itself, okay? So yes, my medication can cause it, but if I have a condition where my body is producing too much, I can still have the same cushingoid experience. All right, this is looking at you saying, right, we had our HPA axis suppression. I'm saying, what do I need to do to prevent this? And how can I taper my patient off of a steroid if they are on the steroid for a very long time? So looking at this, y'all have heard this a gazillion times by now, right? The higher the dose, the longer that they're on it, the more likely you are to see that HPA axis suppression because of the negative feedback. It just shuts it down and says, I don't need to do it because I have the end result. I have the cortisol there. So there's no need for me to go through all of those steps. So if you have a person who's been on steroids for a very long time, or they've been on a very high dose of steroid, you're going to need to taper them off. With our burst, you won't see us do that, right? Because it's a short amount of time that we're doing it, and we usually have a dose that's not very high for that patient. In this situation, when you're usually having to taper off, it's because somebody is on it for a longer period of time. So when you're looking at this, you're usually going to take over 2 weeks to taper someone off of it, all right? That's what I want you to remember is it takes a while for us to taper them off. And what we're trying to do is let that HPA axis wake back up again and say, hey, they're going to take this drug away from me. Now I actually have to do some work. They're not just giving me that end result. They're not just giving me the cortisol anymore. So the taper is to try to say, wake back up, it's time for you to do this. That's why we don't just pull it. So 5 to 20% every 1 to 2 weeks. Again, it depends on what's going on. If you see that somebody's disease, whatever it is, it's starting to come back or they have those flu-like symptoms appear, then you slow down your taper. Increase the dose back up a little bit to where your patient is comfortable again, and now you're going to say, okay, instead of if you did 15%, maybe you'll say, okay, now I'll do 10%. If you were doing it every week, now you'll say, okay, I need to slow down. I'll do it every 2 weeks instead. Sometimes you have to do it even longer than that, depending on the dose that your patient was getting, okay? So if you see that disease flare, if you see those flu-like symptoms, that's your hint that you're tapering too fast for that patient. So you'll bump their dose back up a little bit, and then you're going to slow down how fast you were tapering it before, okay? Your shorter acting steroids, we'll get into this, but sometimes we have our meds that are, somebody might be on a longer acting steroid because they had a chronic disease state that we are trying to manage, and we want to make it to where they don't have to take their steroids several times a day. When you're tapering off of something, you can potentially switch to that shorter acting so you can manipulate, one, the dose, but also how often it's they're going to have to take it and how long it's going to be in their body, right? Because I'm trying to get their body to wake back up to do the thing. I need your body now to make its own cortisol, not me. Okay, so that's why you will see that option to switch. We already talked to you guys a lot about making sure that we keep it in the morning if we can. So again, that's why we like those longer acting ones, because if I give it in the morning, then they can just take it that one time a day and I don't have to keep worrying about them taking it over and over again. And it's mimicking that natural cycle where our cortisol is peaking in the morning. And then looking at the last line, this depends on the provider. Some people are very good with like looking at their patient and saying, I think that they're okay. This is the safest thing to do, which is not always the thing that we do. So what this is saying is essentially get a lab in the morning, figure out what their cortisol level looks like as you've been tapering. So like when you get to the end of the taper, so that you can see, is their body making this cortisol on its own before you pull the med? Because if you pull the med, then you know that they're probably going to have a flare. And so this is just trying to make sure that the HPA axis will back up again. Bless you. This is telling you when you're not likely to see suppression. So if I'm having someone on it for less than 3 weeks, is the broad rule. What we say in practice and what I've heard a lot in practice is people are likely to be careful. They want to be safe and not sorry. So we usually limit this to less than that 2 weeks that I told you about on the previous slide. So you'll see 3 weeks, but what we typically do is we'll say, hey, if they have been on something for over 2 weeks, then we're going to taper them off because we are suspecting that they could potentially have that HPA axis suppression. So on this, if I ask you a question, I want you to focus on this one. I don't want you to think the 3 weeks, because if you do it that long, you could potentially have HPA axis suppression. So think about 2 weeks. Textbook, though, it does tell you 3 weeks could be potentially an option. It says 2 to 3 weeks, but 2. Okay, I'm gonna stick to one number for you to make it easier. 2 weeks. Okay. If you were being unique with your dosing and you did every other day dosing, What this does is it says, hey, I'm going to give you that cortisol on this day, but I'm not giving it to you on the next day so that the body, the HPA axis doesn't shut down. So it kind of makes it stimulate itself, and they're still getting the dose of the medication. So this helps us not have to worry about the HPA axis suppression morning doses like we said. HPA axis is likely if you are having a higher dose of that prednisone, so higher than your 20 milligrams of prednisone. We'll talk about the equivalents later, and they've been using it for greater than that 3 weeks. Again, we usually look at 2 weeks and we start to worry. If they've been on it because they have a chronic disease and they've been on it for longer than a month, regardless of what the dose is, that is also a problem, right? Because now my body has been out of commission. My HPA axis has been shut down for a month. I forgot how to do it. And then looking at your dosing for if they're taking it at bedtime or in the evening, that's not mimicking the natural cycle. So again, you can see where that kind of will cause that suppression to occur. And then if they have that cushingoid experience, that cushingoid side effect, what happens there is now you know that maybe I've given them too much, right? So if you start to see their skin change, they start to get like that round, call it like a moon face or a buffalo hump. They have a hump that starts to develop also in the back of their neck. You start to see those things, you're like, oh crap, my HPA axis is probably shut down. Okay, so that's where you're likely to see this occur. And then this is like that unknown area. I'm not going to ask you about this. So focus here where it's not likely, where it is likely, and then make sure here, yes, you can see 3 weeks, but I want you to be careful, so I want you to put 2. Okay. This is again the pictures of what's happening, likely not reversible. And then this is where you can see the spider veins that happen to the patient. And then this is sometimes that skin atrophy and their skin kind of looks drier, it looks rougher in that area, and that's just from that long-term use that they're having. And again, this they're usually stuck with. It may shrink as they start to lose weight from not being on the steroid and not look as bad, but it's in their, at that point their skin has been damaged, okay? So that would be like that. Again, this is looking at your different potencies that you have, so low, medium, and high potency steroids. This is just telling you the same principles that we've already learned, right? If it's in one of those thinner areas, my eyelids, my diaper area, what do you think about a diaper area? Why am I worried about that area? Not only is it thinner, but what else am I doing when I put on a diaper? I'm covering it up, I'm including it. So now I just increase my potency of my steroid, right? If I did have a medium or a high potency steroid. So same thing with our, like with adults, same thing, that's why we're worried about that. And then again, remember the body folds, again, that's natural occlusion, so making sure that you're sticking with your lower potency. These are your typical times where you're gonna see your medium potency, and then this is your high potency. If I'm asking you about any of this, I'm gonna ask you in the sense of what we talked about in the derm lecture. I'm not expecting for you to go through and try to remember all of these other things. So if it wasn't mentioned in the derm lecture, or which potency you're using it for, I'm not worried about it. Okay, so don't try to go and remember everything from this, and then this was just that general rule that we talked about. So I probably remember this one because it's smaller, and then this, if I told you about it when we were looking at the derm lecture, that's where I want you to know about it, okay? All right, you've seen this already. The vehicles matter, okay? This is the same thing that we talked about before with the vehicle. So when I'm using my ointment, in my thicker areas, I wanted to try to moisturize that area and keep my medication there for a long period of time so that it can go through the skin. My creams are great, lotions and gels, we like those in the scalp and the hairy areas, and want to have them help us with kind of drying things out. And then your foams and your mousses, remember when you're looking at some of these, they may be a little bit more expensive, but they work very well, good for your scalp and your hairy areas. All right, this is your money maker slide that we're going to do before we go to the break. So, low, medium, high, and very high potency. You're going to have to know which steroid goes into which category. Now, I'm not going to make up if it's a cream, if it's a lotion, like I'm not going to do that. I'm going to give you the percentages because what you see is that some of these overlap, right? So this says triamcinolone 0.025 for low potency, but I also see triamcinolone 0.1 and 0.5 in my medium potency. So the strength, the percentage that you see plays a role. There are some of these that the vehicle can also change it. I'm not going to mess with that. That's too much. Okay, so just focus on your percentages and knowing what is the drug that goes in that category, because I can just simply say which one is a high potency, which one is a very high potency. Same thing over here. The only one that this is what I was telling you about where it does change based off of the vehicle. So here for your high potency, you see that it's low, it's a lotion and a cream, whereas over here you see that it's an ointment and a gel. And the way that I kind of think about the very high potency is that it's staying there for a longer period of time with that ointment and the gel, because it goes so easily into the skin, it's staying. This is the only one that I want you to worry about the vehicle. All of these, just pay attention to the percentage. So that's why this vehicle is underlined. Okay. Low, my diaper area, my eyelids, my skin folds, my peds patients, my elderly patients, low potency. Your medium potency, again, just going through this, I don't want to have to read anything to y'all. I underlined the valerate just because you see hydrocortisone here, but because it's a different formulation, that's why you see it now in the medium potency. Okay. Fluocinolide is in both of these, but again, the strength is increasing as the potency is increasing. So if you remember your starting potency and kind of how to go up, it's okay. And again, this is the only vehicle that I want you to pay attention to, the ointment and the gel of your augmented betamethasone as your very high versus your lotion and your cream, which is your high. Okay. Other than that, look at the strengths, and as the strength starts to increase, then you'll see a difference in the potency going up. Okay. This is going to be different than when you're looking at your oral options, because we look at potency different for our oral options. So pay attention to also the difference between my percentages and when I talk about my milligrams. Yes.
We still have like the risk for 10 loggers when
Yes. Yes. I will always give y'all that. Let me see if any of these have two. I'll go with the first one for triamcinolone, because I will use Kenalog. And then for your clobetasol, I'll use Clobex for the brand. I'm not going to write 3 brand names or 2. I'll just write 1. Okay? So Kenalog is the brand name that I'll use for your triamcinolone. Clobex is the one that I will use for the clobetasol. All right? Only vehicle is this one, the very high potency with your betamethasone. All right, let's break and then we'll come back.
It's all my night. Everyone's praying for my downfall. It's
So good. Sarah's trying to make it quiet. This is gonna make me worry. Yeah, oh yeah, we do.
Yeah, like one of the Indian Ocean. Yeah, he had it for cover this morning. Spray paint the side of the the freaking lateral.
PT or something.
Yeah, I changed it. I got bored of the aliens. Yeah. I got bored of it. Double look. I was trying to think, oh shit, really? The second lieutenant thing. It was the UA lens, but I was like, I'm gonna trick people and like, maybe the army system. Like, I saw that place I saw last night. There's a Panther with arms. Yeah. Yeah, that's the thing. I'm gonna get slot machines. Shamrocks. Nobody's responding when I send places. What are you talking about? I sent that exact same place and you didn't say shit. I sent an updated one for this in my Instagram chat. I like that place is similar. So it's perfect. Yeah, I don't mind driving. I like they have a lot of options. I was like, I said on the last night. That's like yeah.
For now, the chicken's suing now because some stuff was going on in Dallas. And I was just like, whatever.
I guess they stopped before 7.
Well, apparently they had a forwarder thing that they were extending it till 9, and then they started separating every Saturday that morning.
So, I would like to just second to last one, the last one.
After 7. And then some matters going
Yeah,
to
she said she'll let me know today.
and it isn't. He wasn't. I was like, I'm not issues. It's all the Republican race. Nothing you can find majority. Attorney General. No, like, yes, for race 4 Attorney General. He's not. He's running. It's also president. Majority. And then,
You heard about that girl that lit herself on fire?
yeah.
That's really close.
Still
Yeah, I don't like driving on that.
Order it from them, do we? That's just easy.
Especially depending on when you get on board. Like if, for example, if I was texting, I both texted like my wife gets on you could if you're able to get the phone place, but phone place always get long, and if you work at 9, phone place is open at 7:30.
Yeah.
But I primary, which means that like so the primary is choosing who's going to represent the party at the actual
My speed. 3 to. Unfortunately, I have to like get my speed because
you go on to the, are you, if you're actually Texas, you go on to, well, I don't have Texas, I go on to Florida, but like, you go on to the Texas, go to like, page whatever it is, and like, make sure you are not carrying, and then like, you can plug it in.
yeah.
Because then,
I'm gonna have
metal, so wherever you're
metal grade.
I got one. There's like a
Why not?
yeah, you'll somewhere in the ground.
It's like
For me,
double-edged sword there.
on mine, it's registered at like my old house, that's like my house.
That's sure. I don't think that's what's gonna take you out.
Yeah.
You think so?
I don't think you pay. Probably MRE.
Oh yeah. Still here. Still going. Still here. Yeah.
Well, thank you.
You're welcome.
I thought you just got tired.
He taught you how to do it? No, like, but yeah, those are really easy.
Yeah.
It's only your belly. Your belly. Going into that one.
You can, you just have to A, change it, or B,
15 hours later,
I know
we were at the lounge. We didn't work there, and it was 6 of us night. We recorded.
Oh, that's good. Okay, conclusion. many cookies you done had now? You eating all the cookies? That's one. I feel like I saw this whole row on the page. All right, so when we talk about our steroids, we talked about occlusions, right? And how sometimes we don't want to occlude. There are situations where you may have your patient occlude on purpose. So when we're looking at this, understanding that I can increase my potency by up to 100%. That is a lot, right? So if I had something that was a low potency, I have now essentially doubled or like made it increase its potency by 100%. That's not what I was trying to do. Now what do I say? My duration of me using that has now also increased, right? Which is not what I wanted to do. When you're looking at this, again, just making sure that you're paying attention to those naturally occluded areas. So if you have, your armpits, you're usually down like this, right? So I'm going to see that if I have somebody who's obese and they have like rolls or like breasts, and somebody has breasts that are larger that could potentially hang, like that is a skin fold now, right? It is occluded. So make sure that you're understanding where someone is putting it. If I wear my socks and my shoes all day, right, and I'm putting steroids on my feet, I am including that area. The diaper, we already talked about the diaper, so just paying attention to the things that are naturally occluded and trying to make sure that, hey, it's winter time. Am I going to put on gloves because now I'm including whatever I could have potentially put on my hand? I'm increasing that absorption, okay? Okay. So the charts. When you look on this, the potency categories that you see here, so 1, 2, 3 to 5, 6 to 7. I'm not going to ask you in that way. I'm just going to ask you low, medium, high, very high. That's just based off of the vasoconstrictor assay. So how much the skin will constrict once you're applying that steroid. So this, you can also see that like these categories, they will vary depending on the source that you're using. So if you look up something or trying to create a mnemonic, make sure you use what I gave you on the slides for your low to your very high potency, okay? So reading from your very high down to your low, we already talked about you need to taper them off a bit, making sure that you're not exceeding that 2 to 4 weeks. We saw this in several of our previous lectures as far as our duration of treatment, and that we can use other things when we're taking our break, okay? So you're intermittently trying to use them, or we're going to do steroid sparing if we can. That is because if I'm in my very high, only 2 to 4 weeks that I can continuously use it. If your patient is continuously or frequently exposed to steroids, then you're sometimes going to lean closer to that 2-week time frame than the 4-week, okay? But if you know, like, hey, I'm just trying to treat this very small thing that's going on, I can push that 4 weeks with my very high. When you're looking at this dose, don't worry about that. What it's saying is the higher the dose, if you have a very high potency, the more likely you are to have that HPA axis suppression, which we've already talked about. But looking at this, what I did want you to remember is that your clobetasol is very, very strong. So here we're saying don't exceed that 50 grams a week. This is saying that as low as 14 grams a week could cause that HPA axis suppression with our clobetasol. So your clobetasol is like your very strong steroid that you have, okay? So when you're going to prescribe this, you're going to be doing this at a lower dose because it takes less to hit that suppression, okay? So just know that it's your strong one. And then looking at your occlusive dressings, again, focusing on the gold whenever we're looking at these charts. So there are some situations where I may say, yes, use the occlusion. I can potentially use it with my fluocinolone, and that's it. Everything else, don't do it. Don't occlude it. Don't put it in a naturally occluded area. If I have to use a very high and it is in an occluded area, your fluocinolone is the only one that you should be prescribing that way. That's all this is saying. So you can remember, which one can I occlude that's very high? My fluocinolone. That's it. All of these other things, that's the only one, okay? Your high potency. Again, just making sure when you can occlude, we're also going to limit the duration of this as well. But making sure that you're not occluding, so with your betamethasone, that's the only one. The other ones now, you can potentially occlude with those. okay? So now you can just have one. Your betamethasone, I can include, that's the only one. Or that's the only one that I can include, sorry, the other ones are fine. And this one, your fluocinidide, is the only one that you can include, the other ones are no. No, did I say that for you? You get in the face. Okay. Your medium potency. So remember, the surface area plays a role. So whatever your condition is that you're trying to treat for your patient, you need to make sure that you're understanding that you're increasing the absorption of that steroid in your patient's body. So if I am looking at a very large area, then that's whenever I'm going to go more so towards my medium potency. If it's a child, remember their body and that equivalency, that's why we stay with our low, because they're still going to potentially get, depending on the area, a medium dose, okay? So your medium potency for an average adult is usually where you're going to go if it is a larger area that they're trying to cover. Very well tolerated in most of our patients, but again, the longer we leave them on them, the more likely we are to see that the cushingoid effects. So use these for less than 3 months is where you're looking at our duration of use versus our 2 to 4 weeks. And then looking at your occlusive dressings, again, just make sure that you're understanding that you're not using it with your betamethasone or your fluticasone. And then your low potency, this is the one that we said, this is like our safest bet. And this is the one that we're using on that delicate skin and our delicate people. So our kids, our pregnant women, our elderly patients, not just elderly women, so elderly, okay? So I think about my low potency as like my gentle steroid that I have. So again, in our folds, we can also use these. This, don't worry about this middle column here because we kind of already discussed that, and I'm not going to ask you which one is OTC versus a prescription. Don't need you to know that because we have all of them in the pharmacy that you can order. But they're hydrocortisone, they can go and buy over the counter. And then your low potency, again, remember those areas, we like it in our, if we were having to use it on the face and those skin folds. So gentle is our low potency, right? Kids, elderly, pregnant, skin folds. And then if I need to use something for a longer period of time, I can also go here with my low potency. Okay, again, this is just putting these drugs now in here so that you can see them all on one chart, and then talking about what we've already discussed with when we're going to use them. So you saw these in the different charts already. So my resistant areas, thicker areas, I'm going to make sure that it's in that ointment form to kind of use those very high potencies. Again, you already saw this, limiting it. Don't go over that 2 to 4 weeks. If you had to go over that 2 to 4 weeks, those drugs that we talked about where we said, oh, these are steroid sparing, you can do that, or you just have to make them take a break. You can use a lower potency potentially, and then you can put them back on it, right? So you're essentially pulse-dosing with your very high if you needed to. Your high potency, again, this is if they can't tolerate this medium, because most of the time we're going to use our medium. If they are not responding how you want them to, then you're going to go up to your high potency. And then again, just like with my less than 3 months for my medium potency, I can do less than 3 months for my high potency as well. So these are kind of grouped together for your duration. And then your low potency, again, we've already talked about all of this, where we prefer to use it. If you did have to use it for a very long period of time, so this is just like a recap of all the things that you kept hearing me say over and over again within one chart, okay? Are y'all okay? You good? No, we're not good. Okay. When we study a little bit, it's going to be okay. So when you're talking about steroids in most topicals, we talked about this with y'all with diclofenac too, and how people will just take it and they put it on, right? You don't know how much you're getting. They might not follow the dosing schedule that they're supposed to, so then they're not going to get the effect that they want. With our steroids, this is very important for them to follow the fingertip unit, because they could be overdosing themselves or giving themselves too much systemic exposure to that steroid. So you have a fingertip unit, and essentially what they're gonna do is they're gonna put one fingertip unit is equal to 0.5 grams, okay? So that's essentially what you're seeing with this picture. All I need you to remember is that one fingertip unit is equal to 0.5 grams, okay? For your mind, so that you can know how much you're ordering, you're essentially saying if I take that, let me show you this next. What you're saying is if I take that, right, one fingertip unit should cover the back of this, the back of this hand and the back of this hand. Now, if you have a very small adult or you have a very large adult, then you kind of are using your mind on your own. I'm not gonna ask you this on the exam, but I'm trying to tell you this because we always have too little of something ordered, and then the patient is gonna be calling you or trying to come back to you, or they're gonna come to me and I can't do anything because I don't have a prescription from you for it, okay? So this little bit is only covering the backs of their hands, all right? So think about if you're telling somebody to put it on their entire back, or if you're telling them to cover their arms or their legs. If I have bigger legs, then you gotta think about the circumference of my legs, okay? Don't give me one little tube because that's not enough, all right? And make sure that you stress to them they're doing the fingertip unit. So one fingertip unit, 0.5 grams. And your tubes are usually gonna be in 15 or 30 gram tubes. Sometimes we have larger tubs that we can also give if it's a larger area that your patient is gonna be applying it, okay? So you have several options as far as the size that you can pick. I don't need you to remember this table. Just remember one fingertip unit, 0.5. This is telling you for a child, you can FYI this is for you to use later. It's just letting you know that that adult fingertip unit, because the child is probably not prescribing their own cream or their ointment. So this is just telling you how the adult would then measure for that child, which is not the same, of course, as an adult, all right? So FYI that, and then FYI this too, because I told you already, I just want you to remember the 0.5 for the one fingertip unit. This is for you to look at later, for you to be able to measure to make sure that you're ordering the right amount. So this is saying like, hey, if you need them to put this on their trunk, the 7 fingertip units is for the front side and then 7 for the back side. And so it's just you adding that up for you to know what grams do I need to order. So then you would do math or add up all of their fingertip units and then see how we supply it. Is it 30 grams? Is it 15 grams a tube? Do we have the big tube? And then you would order the right amount, okay? So I'm not making you do fingertip unit math. I just want you to know that one is 0.5 grams, okay? Use this picture later when you actually start ordering these. Okay. Now we talked about oral steroids. We talked about using these in our severe exacerbations. We had our IV option and we had our oral options and giving them bursts if they were having frequent exacerbations. So what this is, you have short, intermediate, and long acting. Like I tell y'all, when you're remembering something, remember your short acting, remember your long acting, everything else kind of falls in between. When you look at this, a lot of times, and I don't want y'all to go down and remember all of these other things, because these are different, you have different responses depending on the type of steroid that you use. So use this for later. I just want you to know what short, intermediate, and long acting is, okay? Prednisone is essentially our gold standard, and we have our equivalencies to that prednisone. So that's like what you're measuring everything up against is this. Bless you. Your dexamethasone is one of your long-acting ones. This is the one that we talked about in asthma, and we said that they like to use this in the ER because it does last for a long period of time. They don't have to keep dosing those patients, right? So this just lets you know short, intermediate, long. Make sure that you're looking at the fact that here it's broken up by essentially their duration of action, not the percentage strength like we talked about with our topicals, okay? So a little bit different. So all I need you to remember is where your short, intermediate, and long fall. Don't try to remember dose equivalencies, any of that other information. Don't need you to know that. All right. When you look at your cortisone, this is one of the ones that fell into your short acting. You have several different formulations that are available for it. You're going to use this when you're looking at your adrenal insufficiency. Hydrocortisone, again, a very popular option that we have available. Several different formulations that you're using it for. And and then your clinical uses. For these slides, I want you to remember what the clinical use is, like focusing on that. I don't need you to remember like, oh, this is a tablet versus this is an injection. I will tell you on the ones if I do want you to remember that as we keep going through, okay? So on this one, clinical uses and the drug and what class it's falling into. All right, intermediate acting, same thing. So we have prednisone. You see again, we have more formulations that are available, and then understanding that this is good for like short-term use. I have some type of acute issue that I'm trying to treat. I also see here that I have a syrup. I want you to pay attention to that. Why do you think I want you to pay attention to the syrup? Kids, right? So make sure that you understand you have a syrup option there. Same thing with our prednisolone. This is the more common one that we use in our kids because of that oral syrup. But again, just understand these are not the same. This is also a medication error that we see. Prednisone and prednisolone are not the same thing. They're not the same strength when you're looking at these syrups. So sometimes we get the order and it doesn't match up with the child as far as like the dose that they would be seeing. So be very deliberate and very careful. Pay attention to when you are doing this, and then go back and use that equivalency chart that I showed you here. Make sure that you're always paying attention to what's going on. Not the same thing, not interchangeable because of the way that we make these drugs. So when you're looking at your prednisone and your prednisolone, they are on the potency chart as the same, but when we manufactured it, the amount of medication that's in that 5 mLs or what have you, each ml is different. So 5 mg per 5 mLs versus your 15 per 5. So when you look at this, this is again the one that we commonly use, which is our prednisolone. The prednisone bottle looks very similar. Sometimes it has this yellow color label, but very similar. But the difference is it will say that it's 5 per 5. Okay, so not the same strength. So you could potentially be overdosing your kiddo if you don't remember which one goes with which. So that's why that is underlined for you guys to remember the difference between the two. So your 15 per 5 is your prednisolone. Okay, it has the larger number. And your prednisone is the 5 per 5. Okay. All right. Methylprednisolone or your Medrol. Has everybody seen a Medrol dose pack before? Yes, they like to we give these out quite a bit, and you will probably likely prescribe these. So what we do with these, they are tapered for the patient, so they don't have to remember to do anything on the actual pack. And you need to make sure you tell them this because we have patients who try to take all of the day 1 pills at one time. So on the pack, it will tell them take before breakfast, take before lunch, take before bedtime. Like it literally says it on there. People flip that thing over and they just punch out all of the pills and they're like, yep, I took them all at one time. It's not what you were supposed to do. Oh, my stomach hurts. Sure it does. You just took all of your steroids at one time. So when you write this prescription, a lot of the times we put take as directed or take as per package. Be very specific and tell them follow the labels on the actual package. Like be clear because they do not look at what it says on there and they just punch them out. And then it defeats the purpose of the dose pack, which is a taper for them. Okay? So again, make sure that you're looking at that 6-day treatment, and then it starts with I feel like it's 6 or 8 on the first row, and then it tapers them down every single day. Your methylprednisolone, this one, just make sure you know that it's an IM injection, methylprednisolone IM, and then you know that this is a different type of formulation because it has acetate after it versus your Medrol dose pack. So depot, that should let you know it's a shot. And remember, I'm giving you the brand name, right? So your depot, remember those last longer in the body. So that's why you'll be able to remember that one. Your methylprednisolone, again, this is the one that we said they would use if somebody had a severe reaction. We gave them their PO of the prednisone, they didn't respond, and I have to hook them up to an IV. This is the one that we like to use for our asthma attacks most of the time, or if somebody had an allergic, anaphylactic response and we couldn't get their airway to open back up, we can use that here as well. And then your triamcinolone, we don't use this as much anymore. I really kind of don't see this in the outpatient setting often, but you do see that we have several formulations. So for this, Recap, make sure you remember that this is a syrup. Make sure that you remember that this is also a syrup, so these are good, your P's are good for your peds patients. They are not equivalent as far as the formulation. So your prednisone is your 5/5, and your prednisolone is your 15/5. Okay, so make sure you're paying attention to that. Your Medrol dose pack, so it'll say Medrol. So your Medrol dose pack, that one is the one that has the taper for your patients. Your acetate, because it says depot, you're gonna know that I am injecting that. That is the form for that one. And then when you look at your methylprednisolone, this is the one that we talked about with our exacerbations. If they weren't responding to oral, I give them this IV. And then know that triamcinolone exists in several formulations, and that's it. Okay. All right. We talked about dexamethasone. We like this one. We were in the ER. Several formulations again. Your clinical uses listed here. Just understand what you're using it for, okay? And then it's a long acting. Does this look like it belongs here? Right? We have ketoconazole. It is classified, right, in a different class. What class do we typically see this, and where do we learn this? Right. But because it blocks steroid production, it has those properties as well. So for completeness, it is here. So you see that you have the non-selective inhibitor of your steroid synthesis, and then therefore it decreases your body's production in corticosteroids. So if somebody had some type of hyper secretion, right, of those glucocorticoids, you can see where this will kind of shut that down. All right. Don't worry about the possible application. Just know that you do see where some people will off-label. That's why it says unapproved. That's the same thing as off-label. Off-label use of doing that. It's kind of a cowboy thing to do, so don't think to use this. If your doc chooses to do that, then fine. Or if you have absolutely nothing else in this situation, then fine. Adverse effects, same things that we saw before, and then of course this is what the use of this would be as far as our steroid, the steroid application of it is adrenal suppression. You can also see the gynecomastia, hypothyroidism, and the increase in their cholesterol. The hypothyroidism, if you stop your ACTH, which is what could potentially happen here, then you can decrease the thyroid production. So that's why that's also that side effect here that you see. All right, 65-year-old female came to your clinic. She tried to do deodorant, and now she has inflamed, itchy, red skin in her armpit. You are going to treat her with a steroid. What do you think is the best thing for us to do in this patient? Why alpha? Armpit. What else about that? Yeah, I feel bad saying that. She's older, right? She's elderly. So that age of 65 is also why you're doing that as well, okay? If you see something like this, it could just say low potency, high, medium, but it could also give you the actual product, the steroid, right? And you have to know which one it falls into, okay? All right, and then real quick, your mineral corticoids that we have, only a few, so it's quick. When we look at this, remember we said that AL was underlined so that we knew that the main thing that we were looking at, our main mineral corticoid, was going to be the aldosterone. So essentially, we talked about this before, it's going to control that blood pressure because it's controlling the fluids and our electrolyte imbalances via the reabsorption of those electrolytes or of the fluid. You do see that we can sometimes have potassium being wasted. We don't clinically say, like, let's use aldosterone for some of these things because it's very hard for us to control it. But just understand what our mechanism of action here is, and that's why you see that we don't typically use that. If I disturb my electrolytes, now I'm causing issues with my heart and so many other things that function based off of these electrolytes that we may have. So it's hard for us to control aldosterone. It's hard for us to contain it, so that's why we don't really love to use it. Your fludrocortisone, again, mechanism is essentially it's a mineral corticoid, okay? Very strong drug. You'll see it potentially used in your adrenal cortical insufficiency or your Addison's disease. That's all I need you to know about it. Just mineral corticoid, right, where it's falling, and then the fact that you can use it for your Addison's disease. Spironolactone, equinarone, have we seen these before? Yes, they're back, okay? With these, instead of that potassium wasting that we saw with the aldosterone on the previous slide, now they're sparing, right? These were our MRAs. And so now we're sparing our potassium, and you'll see that sodium and the polyuria, all of those things being wasted and being kicked out. So this was our diuretic that we had that provided that mortality benefit, but it is an MRA or a mineral corticoid antagonist, so that's why you see it here. Talk to you about all these, so then just looking at your clinical uses, make sure that you remember those. Your adverse effects, make sure that you remember those, okay? So the name of this game is making sure that you're using the right steroid with the right strength, in the right vehicle, in the right location for the right amount of time, all right? That's those charts that you saw, making sure that all of this makes sense and that we're not hurting our patients by using it for longer than we should, which is the thing that kind of happens, is that they use them for too long. Your memory jogs are here. So again, just kind of going through it as a review once you go through this slide deck. Okay. I want an intro to our contraceptives because I want to try to finish this because y'all have a week of next week we don't see each other at all, and then we'll see each other again after that, and then we move the test from that Monday to that Friday, as y'all are aware. So you have more time. Please use the more time to study, okay? Yeah, I do. All right. Fertility and reproduction when we talk about our contraceptives. So this lecture is one of the longer ones, but you are going to see some of this stuff again when you do women's health. So kind of pay attention to it because it'll help next semester with like making your life a little bit easier. PLOs are the same exact things that we talked about before. And then here is a little background for you. I put this because test questions will use these words and people don't know what these words mean. And so I want to make sure that we're understanding what the words are. So ovulation is when an egg is being released from the ovary, right? And this is when someone can potentially become pregnant. Your menstruation, which is also a term for when people say a period, when somebody says menses, all of these things, their cycle. This is just saying they're actually bleeding. There's actual discharge that is happening. And then your endometrium is the lining that they're usually shedding during their menstruation. They're usually shedding that lining during their cycle, okay? So please make sure that you understand the difference between these words because people get confused on the exam when they see these words, okay? All right, so contraceptives, essentially what I'm trying to do if I have a contraceptive, the main thing is to prevent pregnancy. We also have other reasons why we use contraceptives. Sometimes our patients may have irregular menstruation. Sometimes people have acne or hormonal imbalances that we can use our contraceptives for. So several different indications. The big thing that comes to mind always is going to be preventing pregnancy. We have several different ways in which we can administer or give that contraceptive. So you have barrier methods, which are going to be the things that your patient is going to have to actually do, right? So diaphragms, cervical caps, condoms. Also, if people can't afford condoms, we do have them at the pharmacy, and they can get them for free. They just come and they get them. We also have a lot of them around at OB as well, because OB said they don't want more babies. Your intrauterine methods, these are also sometimes called LARCs. So what they do is you have a copper IUD, you also have a hormonal IUD, and it is inserted by potentially you, a healthcare provider, has to put that that in for the patient. Our sterilization methods, so you can put in a permanent implant that would block the tubes. You can also tie them, they burn them, they treat them meanly. No, I'm just kidding. So you have different sterilization methods, a vasectomy, or when people say, oh, I got snipped, so that they're not essentially trying to get pregnant again. These are more difficult to reverse. They can potentially be reversed, but most of the time this is like, make sure that you don't want kids before you get to a sterilization method for men and for women. And then your hormonal methods, which is one of the most popular ones, kind of now competing with these LARCs. But you have several different hormonal methods that you have. So we have pills, we have rings, bless you, we have patches. So when you see OCP, that is the abbreviation for oral contraceptive pill, and then there's two categories in that. You have your combined oral contraceptives, which has estrogen and progestin, and then you have what's called a POP, which is a progestin-only pill, okay? And we're going to go into detail so that you know the difference between the two and when one is preferred over the other, because there's different reasons why we like some and why we don't like some. Your patches, these used to be very popular, not as popular anymore because people were having a lot of side effects from them, increased a lot of VTE risk in a lot of our patients. So we didn't use these as much anymore. Rings, they're coming out with several different rings now. The newer ring is the main one that had been there. And now they have one that you can use for an entire year. I mean, they take it out in between, have a cycle, and they put it back in. Whereas the newer ring, you just put it in once and then you throw it away after. And then you have injectables, implantable rods, and then our emergency contraceptive pills are also different hormonal methods that we have for contraceptive. So make sure that you always get this complete medical history that we're going to talk about, because certain conditions that someone may have that may seem very mundane can be very big issues whenever you're starting to add on estrogen. Estrogen is usually your big problem that you're worried about when we're talking about any of these contraceptives that have estrogen in them. All right, effectiveness. What trend do you see here with the effectiveness? What seems to be more effective? Not besides not having sex. Okay? Besides not having sex. Sterilize. So these things are more permanent and they involve you and not the patient. As you start to rely on the patient to do something, your effectiveness starts to go down. You want me to take a pill every day? What? I forgot. Right? So now I'm not as effective because I'm not taking it consistently. If I'm not taking something consistently, what happens to my drug level in that therapeutic range? It's falling out of it. Am I working now? No. Can I get pregnant? Possibly, depending on how long I forgot to take it. Okay? So these things, a condom, cervical cap, did I remember to put it in? Did I remember to put the condom on? Right? Because if I don't, it's not going to work because it's in the patent or it's in the sponge pack, right? So again, the more you leave the patient out of it, the better the effectiveness is, especially if you have someone who is not adherent. You have a person who does not follow directions well. Up here is a better option. We like our long-acting reversible contraceptives. You'll hear those referred to as LARCs. So that's the implant or an IUD. So the implant, when they put them in, they just make a very small incision. They put the birth control into their arm. They put it in different places, most of the time in the arm. And then with the IUD, again, it's a procedure that you can do. They go in and they put the device in the uterus so that they don't get pregnant. So that is the best thing for someone who is like, I'm not going to remember to do that. Okay. A ring is also another option that they have as well. So when you're looking at your barrier contraceptive methods that you have male condoms, we have female condoms. Most of the time, we're looking at the guys, right? Use a male condom. You don't see female condoms used as much anymore. Most of the time, it's the male condom. Make sure that if someone is allergic to latex, that they are not using a regular condom, that they have to get the lambskin condoms. But the thing with the lambskin condoms is that they don't protect them from any of the STIs and STDs. Right? Which is why most of the time outside of pregnancy, people are using protection. All right? So make sure that that is a big thing that you let your patient know, because a lot of people don't know that. They see a condom and they're thinking that it's protecting them and it's not. Your female condom, again, single use type of thing. They're using it for that one time and then they throw it away. Your diaphragms, when we look at these are going to be made in different kind of ways, because if you have someone that is allergic to latex, we can also make it with the soft rubber as well. Essentially what it's trying to do is not allow the sperm to get in and cause fertilization if they're ovulating and that egg is being released. So essentially this is saying I don't want to have any babies, right? No babies. You're using it with that spermicidal cream or jelly, another way for us to make sure that if sperm does come in contact with that sponge or in that area, that the spermicidal jelly will kill the sperm as well. So you have two kind of things working together. Make sure that they are not immediately removing it, because what if the sperm are still hanging out, right? So that's why they're waiting the 6 to 8 hours to allow the time for that spermicide to work and to kill any sperm that are there. So it needs to remain in place for at least 6 to 8 hours, but make sure that they don't leave it in over the 24 hours, okay? So it is something that should be taken out. They can reuse this, so they should clean it, make sure that it is dried before they store it away. Because again, some people will wash these, they put them in a bag or they put them in a pouch, and now they're allowing things to grow on the thing that was supposed to protect them and now they can infect themselves. So again, just make sure it's being cleaned properly and that it is dry before they seal it in whatever they're sealing it in. You could potentially be fitting these and then making sure that they get them refitted to make sure that they don't get pregnant, right? Because things can always change in your body. So that's why you see that they're coming back in for it to be replaced every 1 to 2 years. Cervical cap, very similar thing, what they're doing as far as how it's supposed to be used. Keep it in place the same amount of time, 6 to 8 hours, and then this one they have up to 48 hours before they need to remove it. Again, same thing, they are going to get fitted by you, they have to come in for you if they need a replacement, they lose it, what have you. Again, if they're going to clean it, same principles, make sure that they're cleaning it properly. Do you think either of these protect against STDs? No. Okay? So the only thing that we have for that is going to be our condom. This is not doing that. Okay? This is just helping protect them against getting pregnant. Birth control sponge and your spermicides. So again, when you're looking at this is just going to try to, it's a barrier, so it's blocking. Staying in place again 6 hours, making sure that they remove it within 30 hours. Is the rule of thumb. Your spermicides, these they can also get over the counter. We don't have this in the pharmacy the last I checked. But essentially what you can do with this is you can use it by itself. Probably not the best idea because that's only one goalie. 2 goalies will always be better, right? So this is an option if that's all that somebody had. But that's why you see it used with all of our caps that we were talking about, the diaphragms. That's why we were using it first, because I have a barrier and I have something that's just in that area to kill any sperm. Whereas this, now I'm by myself trying to fight, okay? So if I have this, again, over the counter, Walgreens, CVS, everywhere they have them, you can just go and pick it up. And then they have different routes in which you can use the foam, the jelly, so it just depends on what your patient prefers. And they have to try them to figure out what it is that they prefer. So giving it as close to sexual encounter as possible is good, but you want it to be able to be in there and move around and do its thing so that before sex occurs, and any sperm get into the vagina that they don't get that person pregnant. And then make sure that they're not trying to actively rinse it out immediately after sex, okay? So not taking like a douche or something like that and trying to rinse it out. It needs to stay there again because it's trying to continue to work to kill the sperm. Tubal implant or ligation. So your implant is again putting a device in there to actually try to block. Your ligation is where you're going in and you're actually trying to tie to make sure that the egg does not get to the uterus to even be fertilized, okay? Sometimes there are complications that can happen with this, and you have ectopic pregnancies, things like that can occur. So some people, they don't want to do the ligation. Sometimes they'll just say like burn them or cut them to make sure that nothing actually gets past up to the patient and what they want to do. Just have that conversation. Your vasectomy, so essentially what this is it's closing off those vas deferens, which is how your sperm is coming out whenever someone ejaculates. So it's not saying that they're not still producing the sperm, it's just not going anywhere now, right? They will still have ejaculate, it just won't contain the sperm in it, okay? Because now you cut off that supply, essentially. May be reversible, but difficult. I have a friend, he had like 4 or 5 kids, and he got his reversed because he got a new wife. So all the other kids were with one mom. He got a new wife, and she didn't have any kids, and she wanted kids. And he was like, I do not want to do this. And he got it reversed. He's like, it's not going to work. Like, they told me it's such a small chance. And she got pregnant. She had a kid, and it was good for her because he ended up passing away. So, like, I was like, oh, that was great that she got to have that with him. So it can happen. Tell people don't think that it won't work, okay? Because it can work. And also when they get a vasectomy, to be careful after they've had the vasectomy, because sometimes there's still sperm that are floating around. I had a friend, her husband got a vasectomy and they got pregnant. I think it was 2 or 3 days after he had his vasectomy. She ended up getting pregnant because it was still there. So you're supposed to do a follow-up test to make sure that you have cut everything is out, okay? So if somebody does a vasectomy, make sure that they do their follow-up lab test. There's always a follow-up lab test that they're supposed to do because they essentially will examine the ejaculate to make sure that there's still no sperm in there and that the procedure actually worked, okay? Because sometimes it doesn't work. All right, and then last thing before we get all into it and so we can get out of here, these are the big things that we're going to be talking about. You're talking about estrogens and you're talking about progestins. When you're looking at the estrogens or a combined oral contraceptive, that is both of these things being in a birth control. So we'll pick one of these and then we'll pick one of these, and that is a combined oral contraceptive. Whereas when you see the progestins or a POP, which is a progestin-only pill, it will just have these. Some of our LARCs also just have progestin. There's no estrogen in them. So make sure that you're like paying attention to, I'm not going to make anything up or, anything crazy. Your estrogens in or start with E. This one is very rarely used, but just understand that these are your estrogens. Anything else that's over here are going to be your progestins, and we're going to talk about the different generations of them, so you will be familiar with them as we continue to go through the slides, okay? So we'll start here tomorrow with our estrogens.